Yeah, good evening all. I welcome you all for the Vijaya Diagnostic Education webinar series. This is a clinical radiological webinar where the clinicians and radiologists both are involved and discuss on very important topics which are very useful for both the clinicians and as well as the radiologists. Today's talk is on the radiological evaluation of erectile dysfunction, which is a very important topic, and sometimes we don't know how to treat it and how to diagnose it many times. Vijaya Diagnostic Center always been in the forefront in bringing new technology, and so continuous professional update is equally important to use the technology for the greater benefit of the patients when we have to use that. I have with me today our chief guest, Dr. Laxman Bellamkonda, a well-known senior urologist and the managing director of Hyderabad Urology and Andrology Hospital, Kottapet, Hyderabad. He will be discussing on clinical perspective of erectile dysfunction and how penile Doppler can be helpful in treating these patients. And I have with me a senior consultant radiologist with a vast experience in ultrasound and especially in penile Dopplers related to erectile dysfunction with use of intracavernous Papaverine injection, which is a gold standard till now. And also I have with me a young and dynamic radiologist, Dr. Varun Raghav, who his special interest is in Sildenafil Doppler, which we are going to popularize it after this discussion. So with this brief introduction, first I would like to invite Dr. Laxman to tell his clinical perspective of erectile dysfunction and when the Doppler test is recommended to his patients. I welcome Dr. Laxman.
Yeah, thank you, Krishna. Thanks for the introduction, and I'm very happy to join with Vijaya Group. And the erectile dysfunction. Then we'll go to the topic. Erectile dysfunction is increasing day by day because I see almost every day I see 50 to 60 patients, out of which almost 15 to 20 patients are erectile dysfunction. Erectile dysfunction means androgy patients. Few of them they come for the evaluation of infertility to a gynecologist, where they express his wife expresses to the gynecologist saying that he is not able to perform. So then the gynecologist is referring to a andrologist for regarding evaluation of infertility problem. And 30% of these infertility problems where we are evaluating, they are having erectile dysfunctions. Out of 100, we evaluate for infertility, almost to 20 to 30% of the people are suffering with erectile dysfunction. That is one aspect. And the incidence is going up because of the lifestyle or whatever the stress and is happening nowadays. Everyone is running after their work, and also this is one reason. So we are evaluating. And as a clinician, when do I write a color Doppler study of the penis? Patients, whoever is coming to me, I am not writing color Doppler straight away. Initially, we are giving some psychological
I think Lakshman's uh, internet connection is not very good. We must probably join in a while. Uh, we will now proceed with Dr. Dr. Raheem, Dr. Abdul Raheem, to deliver his talk on Papaverine Penile Doppler, an established technique to diagnose different arterial and venous causes of erectile dysfunction. As I know, the Papaverine Penile Doppler is a gold standard technique till date to diagnose arterial incompetence and venous incompetence in diagnosis of erectile dysfunction cases. I invite Dr. Raheem, senior consultant from Vijaya Diagnostics Himayat Nagar branch, to deliver his talk on Papaverine injection induced penile Doppler. I welcome Dr. Raheem.
Thank you, Dr. Krishna Mohan sir, for coordinating this session, and I also thank Dr. Laxman sir, a senior urologist, for being the guest of this session, and my colleague Dr. Varun also for joining me for this session.
Yes, Raheem, we
So
are ready.
today,
Yeah, you can go ahead.
today we will be discussing about the erectile dysfunction, penile Doppler, and technique and interpretation of the penile Doppler. So erectile dysfunction is a common medical condition, and it has nowadays it has high prevalence and incidence worldwide, and this has a very significant impact on both physical and psychosocial health. So coming to the etiology of the erectile dysfunction, we have the organic causes. In the organic, we have neurogenic, hormonal, vasculogenic, and drug-induced, and psychogenic and mixed. So in this talk, we will be discussing only about the vasculogenic cause of erectile dysfunction. So, and the other important etiology for the erectile dysfunction can be the age. So generally in some publications, it has been mentioned that 40 to 70 years age, they are having mild to moderate erectile dysfunction in around 52% of the cases. So coming to the penile erection, so it is a complex phenomena, and by definition, it is a persistent inability to attain or maintain penile erection sufficient for the sexual intercourse. And this penile erection, it is a complex phenomenon, so that coordinates the arterial, venous, and the nervous system. And any incoordination between any of these systems can lead to erectile dysfunction. So before going to the this penile Doppler technique and interpretation post vasoactive drugs, just I will briefly tell about the penile anatomy, the vascular and venous drainage. So here you can see the penile anatomy, transverse cross section, and this is a corpora cavernosa, corpora sponjosa, and it is surrounded by three fascias: tunica albuginea, Buck's fascia, and Daughter's fascia. So mainly in the penile Doppler study, we are concerned with this corpora cavernosa and the sinuses. And this is the main penile arterial supply. Mainly it is from the internal pudendal artery. It is a branch of anterior branch of ICA, iliac artery. So here this internal pudendal artery divides into three. This is a dorsal artery, this is a cavernosal artery, and this is bulbourethral artery. In the penile Doppler, mainly we will be evaluating this cavernosal artery. So, and this is the venous drainage. Most of the venous drainage goes to this internal pudendal vein and the prostatic venous plexus. So coming to the subject proper, this penile Doppler in the evaluation of erectile dysfunction. So the most important thing in the penile Doppler is that we are giving some, unlike other Dopplers, we are giving some drugs, vasoactive drugs to the patient. So prior, so discussion with the patient, verbal and written discussion and informed consent is very important. And because in this penile Doppler, there is a risk of priapism in some 5 to 10% of the cases. So for evaluation of erectile dysfunction, this main role is, as earlier I have said, it is for the differentiation of the vascular and non-vascular causes. So prior to the penile Doppler examination, just we can ask the patient to, if he is on any drugs, we can ask him to stop the drugs and smoking, alcohol. And this penile Doppler is performed with a high frequency transducer, and generally for the injection of the vasoactive drugs, we are using a normal diabetic 1 ml syringe, which is very fine, which causes minimal trauma to the caverns. So coming to the penile Doppler proper. So here the drugs that we are using in the penile Doppler ultrasound is this vasoactive drugs. Generally here in our center we use generally Papaverine, 60 milligrams, which is a 2 ml papaverine. So this directly we injected into the intercavernosally. So we inject it only on one side because this tunica albuzin is perforated. So one side injection will be sufficient. The other vasoactive drug that can be injected for penile Doppler is this 10 to 15 micrograms prostaglandin E1, that is it's called alpha-prostate. So they sometimes in other centers who are resistant to this drug, sometimes a cocktail vasoactive drugs can be used. This can be combined with the phenethylamine. This is an alpha adrenergic. So before giving the vasoactive drugs, we have to take some baseline measurements and measure the peak systolic and end diastolic velocities and the cavernosal artery main diameter, baseline diameter, and grayscale evaluation of the corpora cavernosa for any fractures, pyronis, plaques, and all can be evaluated. So a baseline screening with the B mode and the Doppler to evaluate these diameters and the systolic and diastolic can be done. So this is the pre-injection baseline anatomy. Here you can see bilateral cavernosa and this not bright cavernosal arteries bilateral, and this is a corpora spongiosum in which the penile unilaterale. So this will less contribute to the erection, and this is the tunica albuginea, which surrounds the both all these three corpora cavernosa and spongiosum. So this is the cross-sectional anatomy of the penis. This is the before giving the injection. This is a cavernosal artery, which is the normal caliber, and these are helical arteries, and these are the sinuses which are flaccid. And after the injection, this cavernosal artery all dilated, and this sinuses gets filled up with the blood, and this and by this tumescence is this reached. So after injection of the papaverine, so we have some protocol for penile Doppler. After injection of the papaverine, we take some serial measurements at a 5-minute interval at 5, 10, 15, 20 minutes. And we measure the inner diameter of the cavernosal artery, and we measure the peak systolic velocities and the end diastolic velocities. And these three parameters are main important in the penile Doppler evaluation of the post-injection. And these are how the cavernosal artery flow reacts after injection of the vasoactive drugs. This is before injection. If we have 5 phases, this is before injection. There will be very minimal or no diastolic flow, and we see only faint systolic flow in the cavernosal artery. And immediately after giving the vasoactive drugs, cavernosal artery starts dilating. It increases in the diameter, and both systolic and diastolic flow increases. And these two phase 2, phase 3 also we have increase, and continuously systolic velocities increases, and in this the diastolic comes to the baseline because this is of the because this is due to the venous compression. So this is the final phases. We get the diastolic flow reversal, and the rigidity is maintained. So how we are going to interpret the penile Doppler after injection? So after taking a serial measurements of 5-minute interval at 5, 10, 15, 20 minutes, so we are measuring peak systolic velocities. So anywhere if the peak systolic velocities are less than 30 centimeters during the examination, then it indicates the arterial dysfunction of the patient. And sometimes it can be considered as 25 to 30 also borderline cases. So the other one for the arterial dysfunction is when there is a difference in when we are measuring both cavernosal arteries, when there is more than 10% variation in the cavernosal arteries velocities, then it can also be considered as an arterial dysfunction. The other thing is the cavernosal diameter. When the diameter does not improve more than 50% of the baseline value, then also it can be considered as an arterial dysfunction. The other thing for the evaluation of the penile Doppler is end-diastolic velocity, and this is mainly used to evaluate the venous incompetence. So when the venous, normally the diastolic flow should come down to the baseline and you should go to a reversal state. So when the diastolic flow is still persisting more than 5 centimeter, so that can be venous incompetence can be concluded for this patient. And if there is a diastolic flow reversal, then the end this venous incompetence can be ruled out. So I will show few cases. So when evaluating the Doppler ultrasound, this angle should be at below 30 to 60 degrees. So then only we will get the values. So this is a case for the arterial incompetence. And here we are seeing velocity not more than 10 centimeters, 6.8 centimeters. So this is this is post injection. This is a case of arterial dysfunction. So this is another case. Here in the right cavernous artery, we are seeing a normal flow velocity is around 44. So this is the left cavernous artery, and here these velocities are not above 16, so it is around 15.7. So this is also a case of arterial dysfunction. So here is another case. This is a venous incompetence post Papaverine injection. So the arterial flow velocities are high, but this diastolic flow is still persisting after 15-20 minutes, and there is no baseline decrease or reversal. So this is a case of venous incompetence. So coming finally to the what are the limitations for this penile Doppler by giving the Papaverine injection. So if the patient is having arterial insufficiency, so venous incompetence cannot be assessed during the Doppler study. So the other one is very apprehensive patients, young patients, when they feel that we are injecting something, they feel very apprehensive and we get a positive result, but that is a false positive because of suboptimal response and sympathetic drive. So in these patients, we can use some cocktail regimes like phenethylamine. So the main complication of penile Doppler is priapism. So priapism means this painful erection, that is iatrogenic erection, which we have induced with Papaverine. If it is persisting for more than 4 hours, so then we call it as priapism, and this is an important complication and should be attended with caution. So the other complications can be pain, hematoma, sometimes fibrosis. These are the complications of penile Doppler. So this is the management of priapism by aspiration of the venous blood, corpora aspiration. The other one is we can give phenylephrine to the intracavernous to decrease the priapism. So coming to the conclusion, so penile Doppler by using Papaverine is a very essential tool. It is mainly to differentiate vascular and non-vascular causes of erectile dysfunction. So the radiologist should be very familiar with the imaging protocols, the limitations, the techniques, and the interpretation of these findings for the appropriate warrant of the patient and management. Thank you. Thank you, sir.
Yeah, thank you, Dr. Raheem, for an excellent presentation. You have given brief overview of penile Doppler and it's the Doppler appearances of arterial incompetence and venous incompetence and other parameters. Thank you so much. Now we'll go on to Dr. Varun Raghav for his talk on Sildenafil induced color Doppler for the assessment of erectile dysfunction, and tell the advantages and disadvantages of Sildenafil Doppler also. Then we'll go for the sessions after this.
Good evening, sir. Thank you for the opportunity. So, Krishna, sir, thank you for the opportunity, as well as my senior radiologist, Dr. Raheem, sir. Thank you, sir, for guidance. And also I thank Dr. Laxman, sir, the guest. So, having said that, we'll go with the Doppler of Sildenafil induced penile Doppler. So, what is a penile Doppler and why is it done? As Dr. Rhymes has rightly said, it is an imaging method of choice for initial investigation of penis to access the anatomy, dynamic blood flow. Also, penile Doppler can be minimally invasive, which is Papaverine Doppler, or non-invasive, which is Sildenafil Doppler. So the grayscale ultrasound penis is used to evaluate the penile anatomy, non-vascular abnormalities like plaques, fibrosis, any defects in case of trauma, any masses or fluid collections. Also, color Doppler and spectral Doppler of penis is used to access the vascular flow direction, displaying the blood flow velocity in the form of waveform, which is a graphical representation. So this is the basic schematic diagram and correlating ultrasound picture of cross section of penis, demonstrating the corpora cavernosa, the corpora spongiosum, and the central penile urethra. The corpora cavernosa contains cavernosal artery each on both sides. It is covered by tunica albuginea, the innermost layer, and the middle layer consists of Buck's fascia, and the outermost layer is the Darto's fascia. So the basic arterial anatomy of penis, as described by Dr. Rhymes, the internal pudendal artery and its branches are the primary source of arterial anatomy. The first three branches of internal pudendal artery include superficial perineal, bulbar, and small urethral arteries. After these arteries, the internal pudendal artery continues as the common penile artery, which further divides into left and right penile arteries, which enters the base of the penis and branch into dorsal artery and cavernosal artery. So the dorsal artery primary supplies the skin, subcutaneous tissue, and glands of penis. The cavernosal artery and helicine branches are the primary source of blood flow to the erectile tissue of the penis. This is a visual representation of penile artery, cavernosal artery on the color as well as on the spectral Doppler. So we can see cavernosal artery branching into helicine arteries and the concerning waveform, which is graphical representation. So before going into the technicality, we can see certain arterial variants which are usually seen during routine penile Dopplers. There can be communication between dorsal, cavernosal, and spongiosal arteries. These are variant anatomy can be seen in high percentage of patients suspected of having arteriogenic cause of impotence. There may be also duplication of cavernosal arteries and cross communication between left and right cavernosal arteries. Incidence of communication between dorsal and cavernosal arteries have been reported in 90% of men. There can be rarely collateral from the urethral arteries. Also, although these anatomical variants do not necessarily result in arterial insufficiency, they may cause inaccurate interpretation if they are not appreciated well. So the basic venous anatomy of penis include emissary veins draining into the corpus cavernosum, which further drain into circumflex veins, which further drain into deep dorsal venous system. The emissary vein may directly drain into the deep dorsal vein. The superficial dorsal vein drains into a distal portion of cavernosa as well as the skin and glands. The most proximal portion of the cavernosa drain into the cavernosal veins, which directly drain into prostatic venous plexus. The superficial and deep dorsal veins are routinely visualized by color Doppler in the midline of the penile shaft. Coming to the physiology of erection, when penis is flaccid, its smooth muscle is in a tonic state. The cavernosal sinusoids are collapsed, cavernosal venues are open. The emissary veins drain the sinusoid spaces and blood circulate into the dorsal veins. During this state, there is relatively high resistance to the blood flow into the penis. Erection starts when there is an autonomic neurogenic impulse which relaxes the cavernosal arterioles as well as sinusoidal spaces. As erection occurs, there is a marked increase of blood flow into the penis as cavernosal arteries dilate, which is accompanied by the relaxation of smooth muscle of corpora cavernosa, resulting in expansion and elongation of cavernosal sinusoids as they fill the blood. Compression of these cavernosal venules between the dilated cavernosal sinusoids and unyielding peripheral tunica albuginea decreases the venous outflow. This veno-occlusive mechanism, which depends upon neurological stimuli, a sufficient supply of arterial blood, and normal function of tunica albuginea, It maintains the sinusoidal distension and rigid erection. Basically, there are 5 stages of erection, which can be defined as latent, tumescent, full erection, rigid erection, and detumescent. What is detumescence? Uh, Here I am explaining the detumescence and phases radiologically and with their graphical representation. In detumescence phase, there is systolic waveform dampened and has monophasic flow with relatively small diastolic component, which is figure number A. There is no diastolic component here. In latent phase, the cavernosal arteries diameter are at their greatest, and there is maximum inflow of blood with minimal resistance. There is also slight increase in the systolic and diastolic blood flow with rounded systolic peak and forward diastolic flow, which is second waveform. Tumescent phase, there are sinusoidal cavities of corpora cavernosa distant with the blood. As intracavernosal pressure rises, there is a dichronic notch which appears at the end of the systole, and the diastolic flow starts to diminish, which is the third waveform. And in full erection phase, there is inflow of blood, as do the diameters of cavernosal arteries. There is veno-occlusive mechanism sets in, with resultant reversal in diastole, and systolic waveform narrows. Maximum systolic velocity is seen in the phase in normal patient with strong pulsations. As soon as we can appreciate the reversal in diastolic flow, venous insufficiency can be ruled out. And rigid erection phase, blood flow ceases, the diameters of cavernosal artery at their narrowest, and there is also narrowing of systolic envelope. So further, erectile dysfunction etiology includes psychogenic, endocrine, pharmacological, as neurological and vascular. Mainly vascular etiology is of concern right now, which includes color Doppler ultrasound. And so what is sildenafil citrate penile Doppler? So sildenafil citrate penile Doppler is a well-chosen alternative to the routine papaverine induced penile Doppler. So having said that, it is reliable in many of the cases, and it also has certain limitations. We'll get into it. The sildenafil citrate protocol involves the baseline study without administration of pharmacological agents. Baseline study includes taking the diameter of the cavernosal artery bilaterally, which is the normal value includes 0.3 to 0.5 mm. So the baseline study includes to evaluate the calcifications or any blocks in cavernosal artery. Also, peak systolic velocity is recorded in baseline study, and as well as end-diastolic flow. Then the patient is asked to take 100 mg of sildenafil citrate orally. The parameters are measured with manual or audiovisual stimulation at 60-minute post-administration, as the serum levels reach peak by this time. Since sildenafil citrate requires a direct stimulus for maximum effectiveness, an audiovisual stimulus for 15 minutes of private continuization visualization of erotic video is given. After that, clinical and Doppler evaluations are again performed at 5-minute intervals until 30 minutes, with the patient still receiving the audiovisual stimulus. So, what is the mechanism of action of sildenafil? It minimizes the breakdown of cyclic GMP by inhibiting cyclic GMP specific phosphodiesterase. The result, which allows cyclic GMP present in both penis and pulmonary vasculature to elicit smooth muscle relaxation, causing vasodilation, and subsequently facilitates pulmonary artery hypertension and increase in the flow of blood into the spongy erectile tissue of penis, which consequently allows its growth of size and become erect and rigid. So here we can see the effect of sildenafil citrate on penile Doppler. On the right, we can see the cavernosal artery pre-medication, and post-medication there is subsequent increase in the diameter, significant increase in the diameter of the penile artery, as well as in the pre-medication you can see certain indentations on the penile artery, whether in the post medication, the penile cavernosal artery is smooth, elongated, dilated. So coming to the graphical representations, the normal PSV before medication is represented here, and the post is represented here, which contributes around 96, and there is no diastolic resistance too. So, as quoted by many reliable international journals, for example, of Journal of Urology by American Urology Association, in volume 166, the mean peak flow velocity significantly increased by oral sildenafil citrate, starting at 30 minutes and achieving maximum value at 60 minutes. There were no significant differences in two methods in mean peak velocity at 1, 5, 10, 20 minutes after the papaverine injection, and 30, 45, 60, 75, 90 minutes after oral sildenafil administration. Penile color Doppler ultrasound with intracavernosal papaverine injection is accepted as gold standard, but color Doppler ultrasound with sildenafil has 90% sensitivity and 100% selectivity for demonstrating arterial insufficiency. Due to prolonged erection in the papaverine group requiring pharmacological detumescence by intracavernous injection, there are no adverse effects of sildenafil observed. So, specific conditions where injection papaverine should be the method of choice for penile Doppler are in a known coronary artery disease with recent development of erectile dysfunction, or in a known erectile dysfunction case with the history of usage of sildenafil proven ineffective. So, that's my presentation. Thank you.
Thank you, Dr. Varun, for an excellent presentation. Now, I invite Dr. Laxman for his comments on both the methods of Doppler studies, sildenafil as well as papaverine.
Yeah. Thank you, Krishna. Thank you, Krishna. Am I audible?
Yes, absolutely.
Yeah. Sorry for the. I was using iPhone. I don't know. It was not connecting with the link what you have given. This is my laptop. I don't know. Still, the video is not coming. I don't know what. Am I? Okay. Yeah. And the reason is the main problem why even I do some of the clinical setup office sildenafil test we are doing without doing any Doppler. That means we give 100 milligrams of sildenafil citrate. We provide some audio-visual erosive videos, and we assess clinically whether the patient is getting erections or not. That office setup sildenafil citrate tests we are doing in the clinical setting, providing one room, separate private room, and we are giving sildenafil citrate 100 milligrams. We observe at 20 minutes, 30 minutes, and at the end 60 minutes. So color Doppler is only complementary for sildenafil citrate, right? If clinically is having good erection, and there is no need for a color Doppler study. So basically, that is why it is not very popular as far as sildenafil citrate 100 milligrams is concerned, because we are trying in clinical setup without a Doppler study. So that is one thing. And second, with 100 milligrams of sildenafil citrate, majority of these patients, they develop headache basically. So headache is a major concern. And another drawback, we don't know the cardiac status of all these patients. If patient is cardiac, having some cardiac event and they are not revealing, then it is a problem. So I am not denying 100 milligram sildenafil citrate with color Doppler, with audiovisual erosions definitely will help. It reduces the complications related to the injection color Doppler studies. So for that, what we suggest, because I am trained in andrology in different centers, Singapore, and I practice, my 30% of practice contributes andrology. So what I suggest is either you go for a bimix or trimix to reduce the complications of the papaverine, because we are giving only papaverine injection 1 ml, that is 30 milligrams are not effective. Some people, they don't know how much to give. They give 60 milligrams, that is 2 ml of the papaverine. Definitely with the 60 milligrams of papaverine, most of these patients will go with priapism, and that may not be reduced in 4 hours. Monthly, I treat at least 4 to 5 cases of priapisms. They are iatrogenic. They were tested with color Doppler studies in different centers in this area, and even cases which I sent to the Vijaya. So they come with the priapisms, many of them. So I treat with I give some phenylephrine mixing with some diluting phenylephrine. I put two butterfly needles on either side of the penis. I irrigate the cavernous muscles with continuous irrigation. That will get subside. So even if urologist is not available, then it is a problem with doing a color Doppler study penis with using Papaverine. So my suggestion, sir, after after doing a color Doppler study, if the patient developed a priapism, before intervening with either phenylephrine or any adrenaline related drugs, you can ask him to divert his mind by some doing some workouts, or if possible, if he gets a privacy, let him go and ejaculate. So ejaculation is one thing that reduces this priapism. So let him go. Anyhow, it is in the erect position. Ask him to go and ejaculate. So once it is ejaculated, so autonomic nervous system will again go back to the normal state, and he will have a detumescence. Otherwise, that is one thing. And using some ice cold or ice over the penis, or taking some coffee or tea that increases the adrenaline in his body. See, ultimately we have to give adrenaline mimicking drug or activity. So encourage him to take some coffee or tea, use some ice or over the penis, and if possible, ask him to go for ejaculation. Anyhow, it is in the erectile mode. And all these things failed. And then if urologist is available, send to us for the detumescence to take place. We give usually phenylephrine and all. So anyhow, if we have them, we aspirate the blood. Sometimes I have done some few shunts also, connecting the corpus cavernosum with corpus spongiosum. We'll take say shunt surgeries. And few of them, those who are not responding with this phenylephrine or whatever the injection. So what I mean to say, don't depend totally on Papaverine. You can get a bimix or trimix now readily available. Injections are available, vials are available. You can give 1 cc or 2 cc of bimix. Bimix, as you know, it contains Papaverine and phentolamine. And trimix will have prostaglandin apart from these two. So if trimix is available, that is a good one. Unfortunately, prostaglandin works little. It will cause little lesser dilatation compared to the Papaverine, but the side effects of the Papaverine we can bring down by adding a alprostadil or phentolamine. So you can take a bimix or trimix. Trimix is the safest drug if you can get. It is available. Of course, it becomes a little expensive, but still we can try. Now it is available. Previously, I used to prepare bimix and trimix. I used to test myself. And I used to test all my patients in clinical setup. So I prepare some bimix or trimix. I give that injection and I will check. Why we do lot of, so if I am writing a color Doppler means either patient is demanding or really patient is needed for the test. Otherwise, because of these priapism complications and some patients they get tested and they will go to their native place. So the next day they come to my hospital clinic. By that time, a lot of clots are formed, or he will develop fibrosis. In future, he may go into a permanent impotence. So you can try sildenafil citrate, yes, 100 milligrams still you can try, but we have to wait. There should be a dedicated radiologist, dedicated team. So it consumes a lot of your time. And Papaverine having side effects, so you have to balance. And the best possible way is if you get a bimix or trimix. Many companies are now manufacturing, and that will be a better one. And the priapism will never happen with trimix. So this is my suggestion, because many people are doing color Dopplers in this area, and monthly at least 4 to 5 cases of priapism I am treating. So the best way is go for bimix or trimix, or give low dose. Start with 0.5 ml of Papaverine if you don't have a bimix or trimix. Then you can go for 1 ml. Don't give 2 ml. 2 ml 60 milligrams is a bigger dose.
Yeah, thank you, Dr. Laxman, for the great clinical inputs.
Yeah.
Definitely, clinical information is very useful because when we send some patient, when you send some patients, only that patient we know. But you are giving the input that there are 4 or 5 patients you get with the priapism every month. I think.
Yeah, this area many centers they are doing color Dopplers. They
Right.
ask, they call me before doing the test. Are you available?
I think
So
definitely a mixture of Papaverine with phentolamine. I think that will help.
alprostadil. Yes, now it is available. I don't
Right.
know. You can check with the cost and proportionately you can increase your price also. Color Doppler study price in the diagnostic center and you can charge. But it is a very safer drug.
So, according to you, why Sildenafil Doppler is not as effective as Papaverine Doppler? Just that is
Obviously, it is a see. The main problem is Papaverine has got only local side effects, whereas sildenafil citrate has got a generalized side effects because you are giving into the blood. It has side effects entire body. The basic problem is mainly headache, and if you wanted to really do with that sildenafil citrate clinical test, you should have a good drug, good company drug, 100 milligrams. You should have a original Viagra. All these local companies, they manufacture sildenafil citrate 100 milligrams. The drug may not be 100 milligrams in that. And the quality of the drug, we don't know. Viagra is the original molecule we have to suggest, but that costs around 500 rupees.
but,
So that we have to
but
assess also. See,
yeah,
the locally available tablets, locally available drugs, the drug composition, the dosage may not be that 100 milligrams. So if you really wanted to give that sildenafil citrate and wanted to go for a color Doppler, the best would be ask the patient to get Viagra, 100 milligrams. That is the original molecule manufactured by the Pfizer company. So it has a good efficacy. So local drugs, I don't know the efficacy, but still we can try. The basic thing is, main problem is time. You have to wait. He has to have audio visuals, and you have to provide him privacy. All these things. So I don't think it's possible in diagnostic centers. So that you have to calculate. If taking the tablet and sitting in the general public, he may not get that arousal. Because all these oral medication, it will enhances the existing potency. It will not start the potency. But these injections doesn't require his potency. So all sildenafil oral medication, definitely patient should have some potency inside. Otherwise, these drugs doesn't work. So because we are testing for the potency, if patient doesn't have because he should have the dream, he should have that inclination, he should have some drive, sexual drive, then only these drugs works, especially oral medicines. Injection doesn't require a drive from patient side. So, but pros and cons both are there. If you really wanted to have minimal complications, the best one would be a trimix or bimix rather than sildenafil citrate. But this is a good option where urologist is not available. You don't want to take any risk, and if someone is doing in the some non-urology area, you don't want any complications. Yes, definitely we can try with sildenafil citrate. Yeah,
yeah. Thank
but
you.
as a andrologist, my view is when you are testing with sildenafil citrate 100 milligrams, provide him a separate room provide audio visuals, and you can test clinically without Doppler also. If it is moderate or rigid enough, you can assess clinically. Of course, in that case, Doppler is a complementary. That is how we clinicians look at.
Yeah, finally,
You
any
got it?
comments from Dr. Raghav about your technique? Yeah, as you rightly following with Dr. Laxman's.
Yeah, 100% agree with Dr. Laxman sir. because even I have there are many patients who have come after sildenafil citrate saying that the urologists are not satisfied, so repeat with papaverine. Also, yeah, the common side effects are headache, as well as in some patients there is complaints of anxiety. Since the systemic side effect sets in more than the local side effects, yeah, uh, papaverine is golden standard. Nobody denies it, but uh, in case of if there is no urologist at on call, or you are the only one who is sitting in the diagnostic center having no access to call a urologist, then yeah, sildenafil citrate can be used, but there should be cautious use of sildenafil citrate.
Keeping in mind the
One must
systemic
know the clinical setup. Yes, one
systemic
must know the clinical.
keep in mind underlying problems, attending
Yeah,
cardiac problems and those things. Yeah.
mainly sildenafil citrate can be used in young patients,
Yes, yes.
like
That is very
between
important.
20 to
Never,
30.
yeah, yeah. Never advise a sildenafil citrate to a patient who is diabetic,
Older.
elderly, more than 55 or 60 years. Don't give sildenafil citrate. We don't know his cardiac status. Although he
Yes.
was not evaluated, we don't know his status of the. So, before evaluation, why should we give such high doses of sildenafil citrate?
Completely agree.
And Raheem, what are your comments after that Lakshman's?
As Dr. Laxman sir rightly said, so papaverine has this definite complication of priapism, and the thing that we follow in our center is we generally before the procedure we nicely communicate with a written and a verbal consent. So we don't after penile Doppler, no patient we send them with the report. So we tell them we have to observe self, and before starting the procedure, also we will talk on phone to the referring urologist. Whether is availability, we are starting the test like that. No, then the patient, the urologist, referring urologist, or the clinician also gives his consent. So and after the test also we educate the patient. So this test has been done. So the result is normal, abnormal. You may feel rigidity that will come down. So when it doesn't come down, you have to contact your urologist like that. So that so definitely we give all these communications and the written and after and the patient has to give the consent also. After giving the consent only we are starting the test. The other one is for all patients, we are not starting with 2 ml papaverine. So we take the history, and if something we feel like the patient is psychogenic or it is not a real vasculogenic etiology, then we start with 1 ml papaverine. So for all patients,
Yeah,
we don't start with the 2 ml papaverine. So older
excellent,
patients,
excellent.
definitely when we have in mind that the patient may have an arteriogenic cause for the erectile dysfunction, then only we give 2 ml. For all patients, we don't give 2 ml. Only
And
start with
yeah,
1
yeah,
ml.
medical legally, I was seeing previously we were giving 2 ml, and many reports now of late probably it reduced the dose, but don't mention the quantity what you have given. Sometimes if it is more 2 ml, if you have
In
mentioned,
the reports, we are not mentioning, sir. If we are giving 1 ml, we are mentioning it as 1 ml only. By default, in the report, it will be 2 ml, but we are correcting it
don't
to 1
mention don't mention 2 ml. Mention either 0.5 or 1 ml. That should be okay.
ml.
2
And if
ml
it is a
is not advocated. Now 2 ml is not advocated because whatever we test, either erection point of view or whatever, we give a escalated doses of all these sildenafil or whatever, either oral or injections, because few of them, if the drugs are not working, we keep them on injection treatments because many patients and few of the patients they are there on follow up. They go with before going for sexual act. They take a injection intracorporeally and they meet with their wife. So I prepare bimix and trimix. That is how we were habituated. So I fill bimix and trimix injections, either papaverine, phentolamine, and alprostadine. So I make three trimix doses. I'll load into the insulin syringes. I prepare 10 doses, 10 doses, and I will give them. Will charge for each dose, and I'll give them. They keep it at home, and we train them how to take these self injections posterior dorsolaterally into the penis. Patients, they are happy. Before meeting with whatever wife or girlfriend, they will take one injection. So that is so. Before giving them, this is your dose. We'll start with the 10 units or 20 units. We escalate the dose. We'll fix up. I will fix up that particular patient is fixing at this particular units number of units. 20 units he is doing well. He is developing good erection. We'll prepare all pre-filled syringes with 20 units only. He will use whenever on demand, whenever he is requiring. So in that way, you can also prepare some injections, some trimix or bimix. I will, if you want, I will help you out. You can get these injections. You can keep these injections with you, 10 or 15 doses, and keep it in the fridge. And whenever the patient is coming for the test, you can give the trimix into the instead of using only Papaverine. So you can store those pre-filled syringes. So they are very small needles. That is anyhow you are giving with insulin syringe only, no? Or you are giving 2cc syringe.
Insulin syringe.
We can use insulin syringes, and you can have pre-filled syringes with you, and you can use that timings for the test. It is very less painful, no priapism, and you can sleep. Patient also can sleep, and you can also sleep nicely. So no need for any urologist if you use this thing.
Thank you, Dr.
So
Laxman.
yeah, this is a very regular practice for me. So monthly I have good VIPs for this purpose. So I give them pre-filled syringes, and they come and collect regularly. Okay.
Thank you, Dr. Laxman, for the great suggestions for using the trimix and trimix. I think we'll try to those, and we try to use, because that can reduce the priapism, which we are really worried about. Thank you, Laxman, Dr. Raheem, and Dr. Raghav, for a wonderful discussion with a lot of clinical insights from Dr. Laxman. I hope this webinar is useful for all the practicing radiologists, urologists, andrologists, and sexologists, and to choose whichever technique is suited for their particular patients, like whether it's a sildenafil when the urologist is not available, or the patient is worried about any injections. And if they want complete information, gold standard information, they can go with either Papaverine, low dose Papaverine injection, or Dimax or Dimix or Trimix injections, which we are going to procure, and we'll try to follow that to prevent further episodes of priapism. Thank you so much, all the participants in this symposium. Thank you so much.
Thank you, Krishna. Congratulations, Dr. Raghav and Raheem. You presented well, and
Thank you very much.
lot of information I got. And sorry for the inconvenience, because my video is not on. I don't know what is the problem. Anyhow, I could see all of you. Thank you so much.
We could hear you very well, Laxman. Everyone, really useful to everyone. Whoever it will be kept in the Facebook and YouTube and everywhere. So patients and referring doctors, urologists, whatever get benefited through these lectures.
Sure.
Thank you so much for participating.
Thank you.
Thank you, sir.
Thank you, Raheem. Thank you, Raghav.
Yeah. Thank you, sir.